Now we'll turn our attention to the blistering skin disorders, of which there are 5. The first two we've actually discussed about to some degree when we were discussing the desmosome and the hemidesmosome. As you may remember, pemphigus vulgaris is a blistering disease that is marked by the finding of IgG antibodies against the desmosome. This causes segments of epidermis to lift off away from one another, which leads to the formation of intraepidermal bullae. It can be very severe. There are 3 classic comparisons made between this and bullous pemphigoid. The first is that when you look on immunofluorescence, you will see a net-like pattern, because the antibodies can be found throughout the epidermal layers between keratinocytes. In contrast, the IgG antibodies against hemidesmosomes found in bullous pemphigoid only attack at the basal layer of the epidermis, because that is truly where all the hemidesmosomes are, and this appears like a line instead of a net. This means when the hemidesmosomes are destroyed, the epidermal layer lifts off the dermal layer in one untouched piece. The second distinction that's often made is that pemphigus vulgaris will affect the skin and oral mucosa, while bullous pemphigoid only affects the skin, not the oral mucosa. Finally, the Nikolsky sign is positive in pemphigus vulgaris and negative in bullous pemphigoid. This means that if you were to stroke the skin would quite literally blister in front of your eyes. While this is a classic description, the other clinical indicators are more likely to help you make the distinction. The final 2 blistering diseases are erythema multiforme and Stevens-Johnson syndrome, which probably shouldn't be thought of as classically blistering diseases. Erythema multiforme and Stevens-Johnson's are the 2 ends of a spectrum that occur as a result of drug reactions, much like the spectrum of cellulitis and neck fash. Erythema multiforme is the most benign reaction, while Stevens-Johnson's is much more serious and potentially life-threatening. Let's start with erythema multiforme. It classically shows a number of different lesions, usually with macules, papules, and vesicles, and some targetoid lesions. A classic finding. Many drugs can cause erythema multiforme, including sulfa, beta-lactams, and phenytoin. Additionally, you may see erythema multiforme as a result of certain infections like mycoplasma and herpes simplex, but this is less common. The other, even less common possibility is that erythema multiforme results from cancer or autoimmune disease. It is worthwhile to know these associations exist, but you should keep erythema multiforme strongly linked to adverse drug reactions for the purpose of step 1. Stevens-Johnson's, in contrast, has more concerning skin findings, usually including bullae with necrotic areas, particularly orally, and is found along with systemic signs like fever. Stevens-Johnson's often occurs at the same time as another skin disorder called toxic epidermal necrolysis, which causes large areas of skin to slough off, making it a life-threatening condition. And now, we've reached the final subsection of skin disorders, the miscellaneous disorders. While these couldn't be categorized into groups already listed, they are worth remembering because most of them have certain pathognomonic findings that help you recognize them clinically. Also, a few of these will actually be indicators of underlying disease as well. The first of these diseases is lichen planus. The skin lesion is classically and always described as pruritic or itchy, purple, polygonal papules. Histopathologically, lichen planus appears as sawtooth infiltrations of lymphocytes at the dermal-epidermal junction. It's also important to recognize that this lesion is associated with hepatitis C. I like to remember that lichen planus with a P shows pruritus, purple, polygonal papules, all P's, and that it's associated with hep C, which also has a P in it. The next lesion is actinic keratosis, a small, rough, red or brown papule that is considered pre-malignant. As you'll see on the next page, there is a risk of squamous cell carcinoma. It's thought to be associated with sun exposure. The next lesion is acanthosis nigricans, another classic example of how a skin finding can indicate a second visceral disease. In this case, acanthosis nigricans, which is a hyperplasia of the stratum spinosum, can be associated with insulin resistance, or a visceral malignancy. Can you remember the other skin finding that is associated with visceral malignancy? That's right, the sign of Lessard-Trélat, or the rapid appearance of multiple seborrheic keratoses. The next finding is erythema nodosum, a skin lesion that causes inflammation of subcutaneous fat, particularly on the front of the shins. There's a huge differential for what diseases have erythema nodosum as part of their presentation, and include fungal infections and tuberculosis, as well as leprosy, streptococcal infections, sarcoidosis, and inflammatory bowel disease. Think ENLIST as an acronym for the finding and the major causes. The next disease we'll discuss is pityriasis rosea. Though you likely won't see it, it's worth knowing because it's marked by 2 classic skin lesions. The first is a herald patch, usually a small patch that occurs initially and heralds the later, more well-known eruption that occurs in a Christmas tree distribution. The disease requires no treatment as it will go away by itself. Skin cancer is an incredibly common type of cancer, and in many cases, not a life-threatening one to have. There are 3 main types: squamous cell carcinoma, basal cell carcinoma, and melanoma, all of which have classic appearances that you should be familiar with for your boards. Squamous cell carcinoma is a skin cancer that is thought to arise from another skin lesion called an actinic keratosis. A variant on this theme is a keratoacanthoma, which usually grows fast, over the course of weeks, but then regresses within weeks after that. When the disease progresses to squamous cell carcinoma, it is usually expected on the hands and face, and may have serious local invasion, but rarely will invade past the basement membrane. On gross appearance, the lesion appears red and may be ulcerated. Histologically, the key finding is the keratin pearl. There are 3 associations with squamous cell carcinoma that you should know. It is associated with sunlight exposure, arsenic exposure, and prior chronic draining sinus tracts. What bacterial genus typically causes chronic draining sinus tracts that discharge sulfur granules? That's right, it's actinomyces. Basal cell carcinomas also occur commonly in sun-exposed areas. They share the same locally aggressive quality and also tend not to metastasize. The classic description is similar to squamous cell in that they ulcerate centrally, but classically they grossly have pearly papules with rolled or heaped up borders that show telangiectasias. Once you see it, you'll never miss it. Under a histologic slide, the key finding is palisading nuclei. The final type of skin cancer is melanoma. This is a serious one. Why? Because unlike squamous cell or basal cell, melanoma can metastasize. The classic question is what aspect of the tumor affects its likelihood to metastasize, and the answer, no matter how it's phrased, is the depth. This is known to surgeons as its Breslow thickness. This kind of makes sense, so it's easy to remember. The deeper skin cancer goes, the worse the prognosis. Makes sense, right? The lesion itself is described with the ABCD memory aid. A for asymmetry, B for irregular borders, C for more than one color, and D for diameter greater than a pencil eraser. Risk factors for melanoma include fair skin and increased exposure to sunlight, as well as prior history of a dysplastic nevus, as this can be a precursor lesion. There's also a tumor marker that can be used as a staining technique if there's a concern for melanoma. That's S100. Just think of S as standing for skin. Of course, if the melanoma is on the skin, it is usually easier to know it is a melanoma, but remember that melanoma has many different forms. The ABCD mnemonic we discussed is best for the common type of melanoma, which is called superficial spreading melanoma, but there are many other types, including nodular and amelanotic or colorless. Also, 20% of cases with metastatic melanoma present without a primary melanoma on the skin. Also, 20% of cases with metastatic melanoma present without a primary melanoma on the skin, presumably because it was small and was defeated by the immune system already. And if you do get a question about metastatic melanoma, remember that melanoma is a mean cancer. It does not follow any rules. It can quite literally grow anywhere in your body, from your gut to your liver to your bone to your brain to your eye. If you ever get a micrograph of a met though, it's pretty easy to figure out it's a melanoma, as melanoma should be uniformly darkly pigmented in any picture you would see on step 1.